Iron Deficiency Anemia by Chanda Anderson and Dana Griffin, Nebraska Methodist College. Learning objectives for iron deficiency anemia are: the participants will be able to describe at least 2 clinical presentations of iron deficiency anemia. The participants will be able to recall at least 3 foods that are rich in iron. The participants will explain the importance the role of diet can have on iron deficiency anemia. The participant will apply knowledge by being aware of iron deficiency anemia and indicate at least 2 risks to the fetus without maternal supplementation. The participants will be able to recognize iron deficiency anemia based on interpreted lab results and report an increased knowledge of lab tests to implement in their professional practice. Iron deficiency is the most common nutritional deficiency and the leading cause of anemia in the world, affecting as many as 1/5 of the population according to Healthy People 2020. The prevalence varies with age, social economic factors, sex, race, and nutritional intake. Lack of iron in the body can be the result of inadequate iron in the diet, reduced absorption in the gastrointestinal tract, and increased iron requirement caused by growth and bleeding. Iron deficiency anemia can affect all ages, with the prevalence increasing with age. Iron deficiency at crucial times of growth and development can result in low birth weight babies, premature births, delayed growth and development, delayed normal infant activity and movement. Iron deficiency can result in poor memory or cognitive impairment and can result in poor performance in school, work, or recreational activities. A gap analysis was identified after a review of multiple articles indicating not all healthcare providers are skilled in identifying best practices in the assessment of clinical presentation and the correct diagnostic testing for iron deficiency anemia. Medication is frequently prescribed to treat iron deficiency anemia instead of encouraging diets with foods high in iron. Medications for iron deficiency anemia can have undesirable side effects associated with them. There is a lack of knowledge in iron supplementation in pregnant women. Pregnant women are not identifying the effects iron deficiency can have on their unborn child. This analytic framework portrays the pathway for screening to supplementation and the relationship of iron status to health outcomes. The analytic framework presented here indicates the current evidence in which you see the solid lines, including the emerging gaps in evidence and research needed, which is the dotted lines, for iron screening and supplementation of pregnant women and children. Etiology and risk factors of iron deficiency anemia. Iron deficiency anemia occurs when the body doesn't have enough iron to produce hemoglobin. The red blood cells are smaller than average and hypochromic due to the lack of hemoglobin. Iron deficiency anemia may be caused by poor or limited diet, poor absorption of iron, or decreased iron absorption from high gastric pH, medications, gastric surgery, vitamin C deficiency, or loss of iron from bleeding. Women of childbearing age 12 to 49 are at high risk of ongoing iron loss due to menstruation and pregnancy. The risk of anemia increases with each trimester of pregnancy. Risk factors for iron deficiency anemia in pregnant women include an iron deficient diet, gastrointestinal issues affecting iron absorption, and a reduced gestational period. Children ages 1 to 2 years are at high risk of iron deficiency anemia than women due to their iron requirements needed to support growth and development. Premature infants' risk increases due to their smaller body size and reduced total body iron contents. Iron deficiency anemia is associated with impaired immune function, impaired neurocognitive development, and impaired psychomotor function. These consequences in the pediatric population are often irreversible. Adolescents with rapid growth and obesity have a higher risk of iron deficiency anemia than individuals at a healthy body weight. Blood donors are also pose a risk factor for iron deficiency anemia. Blood donors deplete their iron stores quicker than can be replenished. Iron loss from gastrointestinal tract is the most common for iron deficiency anemia. Common causes of gastrointestinal blood loss are from carcinoma, ulcerations, parasites in the third world countries, and malformation of the gut. Other blood loss may be caused from nosebleeds, hemoptysis, or hematuria. Pathophysiology. Iron deficiency anemia can arise from etiologies of inadequate dietary intake or excessive blood loss. In addition, metabolic disorders lead to insufficient iron delivery to the bone marrow or impaired use of iron. The body maintains a balance between iron that is contained in the hemoglobin and iron that is in storage or available for future hemoglobin synthesis. Iron in the form of hemoglobin is in constant demand from the body. Iron deficiency anemia occurs when the iron demand exceeds the supply and develops slowly through three stages. First, the body's iron stores are depleted. Erythropoiesis proceeds as normal, with the hemoglobin content of the erythrocytes remaining normal. Iron transportation to the bone marrow becomes diminished, resulting in iron deficiency erythropoiesis. Small hemoglobin deficient cells then enter the circulation to replace the normal aged erythrocytes that have been removed from the circulation. Having too little oxygen in the body can damage internal organs. The heart works harder to make up for the lack of red blood cells, which is the hemoglobin, that is not being carried throughout the body. This extra workload causes increased stress and harm to the heart, causing tachycardia, exercise intolerance, and a cognitive decline. Next, let's take a look at the diagnostic criteria. Iron deficiency anemia may be asymptomatic in its early stages. When the total body stores begin depleting, causing the clinical presentation of weakness, irritability, headaches, and fatigue to arise, the patients often present with pallor, tachycardia, pale conjunctiva, spoon-shaped nails, glossitis, exercise intolerance, cognitive decline, and a change in stool size, bowel habits, epigastric pain, weight loss, poor appetite, and premature satiety. Anemia in adults is defined as a hemoglobin less than 13 for males and 12 for women. To classify and diagnose iron deficiency anemia, a CBC is used to determine the hemoglobin and the mean corpuscle value. Using the mean corpuscle value indicates the volume of the red blood cells in which, if less than 80, they are microcytic, indicating iron deficiency anemia. These two indications help decide the use of further lab tests of a serum ferritin, total iron binding capacity, transferrin saturation, and serum iron. Due to the lack of iron in the serum ferritin and serum iron levels will be low, with the total iron binding capacity being high. The total iron binding capacity is elevated as the liver is attempting to compensate for the low serum iron levels by increasing the synthesis of the transferrin. Iron levels are determined by absorption and depleted only from the body as blood loss. Now let's take a look at the interpretation of lab results in iron deficiency anemia. The most commonly used and cost-effective tool for anemia is the CBC, a complete blood count. To identify the underlying cause of anemia, the hemoglobin and the mean corpuscular volume, MCV, become the useful part of the CBC. The MCV is the average number of red blood cells. The parameter of a hemoglobin less than 13 in a male and 12 in a female adult classifies anemia. To further delineate microcytic anemia, known as iron deficiency anemia, the use of the MCV value is used. An MCV of less than 80 indicates microcytic anemia and helps to narrow the differential diagnosis and guide further testing. Further testing would include the serum iron, iron binding capacity, serum ferritin, and the transferrin saturation. Complete health history, physical assessment, medication history, and dietary intake of the patient should be obtained to evaluate the patients according to their signs and symptoms. Women of childbearing ages should have a menstrual, pregnancy, and lactation history recorded. If the patient is an infant or a child, the birth history is indicated in a complete health history. Now that you have an understanding of the etiology, risk factors, pathophysiology, diagnostic criteria, and interpretations of the lab results, let's look at a case study. Here is a case study of a 28-year-old man who suffered from an ischemic stroke due to severe anemia. A 28-year-old man presented to the emergency room department complaining of profound fatigue, chest pain on exertion, dizziness, double vision, and headaches. He admitted to heavy marijuana and alcohol use. Physical exam revealed a thin man who was tachycardic and had a soft apical murmur and poor dental hygiene. Ophthalmic examination revealed strabismus of the left eye, diffuse retinal hemorrhages, and Roth spots indicating intracranial hemorrhage. An electrocardiogram was normal. The MRI revealed evidence of a stroke with a 4-millimeter lesion of the right midbrain with ischemia. A complete blood count showed a hemoglobin level of 1.12, with the normal being 13 to 17, and a platelet count of 16,000, which is generally 150,000 to 450,000. Repeat CBCs 2 hours and 6 hours later revealed a 1.28 and a 1.73, and a repeated platelet count was 7,000. The patient was emergently transfused with a total of 6 units of packed red blood cells and 1 unit of platelets over the next 3 days. Further workup that displayed no evidence for a source of emboli, large loss of blood volume, or underlying genetic predisposition for any blood dyscrasias. He was started on iron supplementation due to a peripheral blood smear displaying severe microcytic and hypochromic red blood cells. After 3 units of packed red blood cells, his presenting clinical symptoms, including his focal neurologic deficits of strabismus, began to resolve. Based upon this gentleman's staggeringly low blood cell counts, a hemoglobin level of 1.12, and otherwise normal workup for a stroke in a man this age, severe anemia was presumed the cause of the stroke. His mean corpuscle volume was low at 58, and his red blood cells were hypochromic. It is believed that iron deficiency anemia was the source for this 28-year-old man's anemia. Recognition of symptoms, pertinent diagnostic tests, and clinical reasoning supported making the diagnosis of iron deficiency anemia as the cause of his ischemic stroke. Healthcare providers are encouraged to be vigilant regarding hemoglobin levels and the prompt treatment of anemia. It may be potentially prevent a cerebrovascular accident and the adverse pathological conditions associated with these devastating events. Even though it is rare to have a 28-year-old man suffer from an ischemic stroke due to severe anemia, understanding the etiology, risk factors, pathophysiology, the diagnostic criteria, and the interpretation of lab results is crucial. Vigilance on the part of healthcare providers regarding hemoglobin levels and the prompt treatment of anemia is warranted. The algorithm in this is a guidance tool in the approach to iron deficiency anemia for healthcare providers. To the left of the screen, you will see that it indicates typical findings of iron deficiency, symptoms, examinations, things that may show, things you will find on the CBC, and other panels that you should do that we talked about in the sense of iron, transferrin, total iron binding capacity, ferritin, and a transferrin saturation. This algorithm provides a guideline for healthcare workers to take a look at anemia, do a diagnostic workup, and eventually treat if indicated for iron deficiency anemia. Now let's look at a typical day in the clinic or office where you can apply what you have learned so far. A 68-year-old man with a known diagnosis of tuberculosis seeks medical attention because of chronic tiredness and palpitations with minimal exertion. He describes to you the gradual onset of these symptoms since last year, but recently noticed his shortness of breath and occasional throbbing headaches were increasing. Physical examination revealed a lean man with obvious pallor, shortness of breath when walking, normal conjunctiva, a smooth tongue, spoon-shaped nails, and his hands were cool to touch. As you begin to examine his chest, it did not reveal any evidence of crackles or consolidation. Heart sounds were audible with a mild systolic ejection murmur, and there was no evidence of edema in his extremities or other abnormal physical findings. The CBC at your office reveals the following values: white blood cells 11.2, red blood cells 4.9, hemoglobin of 8.7, a hematocrit of 24%, MCV at 68, MCH 17.7, MCHC 26.1, RDW at 23, platelets at 552, neutrophils at 55%, lymphocytes at 32%, monocytes at 8%, eosinophils at 5%, and basophils at 0%. Classifying an anemia as microcytic, macrocytic, or normocytic is based on the cellular erythrocyte size, which corresponds to the mean corpuscle volume, the MCV, measurement, and the hemoglobin content, resembling the mean corpuscle hemoglobin concentration measurements. In the elderly population, anemia is associated with various chronic inflammation diseases, chronic kidney disease, malignancies, bone marrow failure, heart failure, malnutrition, and nutritional deficiencies. These individuals may present with different signs and symptoms of anemia, depending on the degree of severity measured by the red blood cells, the hemoglobin, and the hematocrit. Classic presentations seen are a pale appearance, fatigue, insomnia, weakness, anorexia, pica, dizziness, palpitations, dyspnea, headache, and decreased mental or physical performance. Anemia in the elderly is common, occurring in more than 10% of the individuals older than 65 years of age and increasing to 50% in individuals greater than 80 years of age. Reasons for increasing prevalence of anemia in the elderly population is still not completely clear and is associated with substantial morbidity and even mortality. The most common cause of anemia in the elderly are anemia of chronic disease and iron deficiency anemia. As we continue with our clinical and office scenario, let's take a look at some other lab values. Here is a depiction of a slide representing a blood smear. To the right of the screen is a normal blood smear. To the left is a blood smear representing iron deficiency anemia. As you can see in the lower right-hand corner is the blood smear of the 68-year-old male that presented to your office today. With that in mind, what are the physiological mechanisms underlining the signs and symptoms of the chief complaints for this patient? In this scenario, the individual is a lean 68-year-old male seeking medical care for chronic tiredness and palpitations on exertion over the past year that has recently progressed to shortness of breath and a throbbing headache. He has a known history of tuberculosis and mild systolic ejection murmur on exam. The chronic tiredness and fatigue associated with the anemia is due to the body's compensation to increase the oxygen in the blood that is oxygen deprived because of the abnormal size or quantity of the red blood cells. Anemia that develops gradually is usually easier to compensate for, yet may cause problems during physical exertion. The continued reduction in red blood cells causes symptoms to become more pronounced and compensatory efforts more apparent in the cardiac and respiratory systems. As the reduction in red blood cells continues, it causes a decrease in the consistency of the volume of the blood. Compensation for the reduced blood volume in return causes the interstitial fluid to move into the intravascular space, therefore expanding the plasma volume. The diluted blood flow flows faster and more turbulent, creating an increased heart rate, stroke volume, and bounding pulse. In anemia, these changes will lead to cardiac dilatation and heart valve insufficiency, similar to the 68-year-old symptoms of tiredness, palpitations, and mild systolic ejection murmur until the underlying anemia condition is corrected. Reduced oxygen levels in the blood create demands on the respiratory and cardiovascular system to meet normal oxygen demands and prevent cardiopulmonary congestion. The rate and depth of breathing increases in an attempt to increase the availability of oxygen. Therefore, compensatory mechanisms cause the 68-year-old to experience continued shortness of breath. Hypoxemia further contributes to the vascular dysfunction, causing headaches secondary to the severe anemia. His skin appearance is pale due to the reduction in hemoglobin concentration. Mycobacterium tuberculosis requires iron for survival, and the individual has a known history of tuberculosis. In tuberculosis, viable bacilli can exist for a lifetime, and if the immune system is compromised with illness, as in anemia, the tuberculosis can be reactivated, creating further breakdown of the red blood cells. So what are the differential diagnoses for this patient? How would you explain laboratory or other tests to support your diagnosis? What differentials would you decide in your office today to choose? Differential diagnoses could be iron deficiency anemia, anemia of chronic disease, thalassemia, HIV, lead poisoning, dehydration, migraines, possible pneumonia, or cytoblastic anemia are just a few of the differentials that could be used. What are some of your differentials? Confirmation of anemia is derived by a lower than normal red blood cells, hemoglobin, and hematocrit. If the MCV is below the normal range, then the anemia is to be considered microcytic. Microcytic anemias, such as iron deficiency anemia, can occur in an adequate dietary intake or gastrointestinal absorption, malnutrition, or blood loss, and is common in the elderly population. The hemoglobin in this individual is 8.7 and indicates the need for further investigation of the underlying cause. What other lab values did you see? Anemia of chronic disease is considered when we know that he has tuberculosis. Tuberculosis and HIV together can create anemia to exacerbate due to the increased iron consumption by the bacilli and the body's response to the failing immune system. Tuberculosis is most common cause of moderate to severe anemia in patients with HIV, with thalassemias being the most common single genetic disorder known in all the ethnic groups in the geographic location of the Mediterranean basin and Asia and Africa. It is important to identify the individual's ethnic background as he has a low MCV. Additionally, there is a high incidence of prevalence for tuberculosis in Africa, and we know he has a known case of tuberculosis. In sideroblastic anemia, the individual may have been exposed to alcohol, lead, or zinc, which are acquired types causing moderate to severe microcytic anemia and have multiple clinical implications suggesting the need for further evaluation. Based on the information provided, the diagnosis chosen is the differential diagnosis is iron deficiency anemia. How does laboratory or additional tests support the diagnosis? What is the treatment plan for this patient? The initial lab, a complete blood count, indicated that the patient has microcytic anemia. Further tests of serum iron level, total iron binding capacity, serum ferritin level, and peripheral blood smear are indicated. The ferritin level is the first to change in iron deficiency anemia. If the level is elevated, a transferrin receptor level can indicate and confirm iron deficiency anemia. If the transferrin receptor level is normal, it may indicate anemia of a chronic disease. A serum iron level decrease and a total iron binding capacity increase can also indicate iron deficiency anemia. No change will occur in the serum iron level or total iron binding capacity with thalassemia and lead poisoning. Bone marrow aspiration is indicated in the presence of abnormal cells, pancytopenia, or to rule out cytoblastic anemia. If questions remain, a hemoglobin A2, globulin synthesis ratio, hemoglobin electrophoresis, including hemoglobin H for thalassemia, can be drawn. A zinc or free photoferrin level for lead poisoning if no indications on the CBC. HIV testing and a chest X-ray for tuberculosis may be indicated. A multidisciplinary approach with gastroenterology for such things as an endoscopy, an EGD, or a colonoscopy, infectious disease for tuberculosis, HIV, possible infection of an unknown origin, hematology for any underlying blood cancer, viral hepatitis that suppresses the bone marrow, and nephrology for renin-aldosterone responses. Consult may be considered if further evaluation and anemia cause cannot be determined. Management of anemias at an older age depends on the severity of the anemia, underlying causes, and the individual's comorbidities. Even a mild anemia can significantly affect the individual's physical and cognitive capabilities and their quality of life. Management and treatment of anemia in older patients often requires a thorough history, medication review, critical evaluation, and a multidisciplinary approach. The goal in anemia is to treat and eradicate the underlying cause. So far, we have explored the prevalence, pathophysiology of anemia, diagnostic criteria, signs and symptoms present in an individual in a case study, as well as in a clinical scenario. Now let's take a look at the recommended treatment for pharmacy with diagnosis with doses, iron supplementation in pregnancy, and most importantly, implications for practice.
The recommended treatment. The role of diet in iron deficiency anemia. If the body doesn't absorb its needed amount of iron, it becomes iron deficient. Eating a well-balanced, healthy diet that includes good sources of iron to prevent any deficiencies is important. Combine vegetarian sources of iron with vitamin C in the same meal. The body absorbs 2 to 3 times more iron from animal sources than from plants. Some of the best animal sources of iron are red meat, pork and poultry, seafood, turkey, oysters. Although you absorb less of the iron in plants, each meal you eat makes a difference. Adding a source of vitamin C to vegetarian sources of iron will increase absorption. Some of the best plant sources of iron are beans, lentils, dark green leafy vegetables such as spinach, iron-fortified breakfast cereals, tofu, baked potatoes, whole grain, and enriched breads, cashews, dried fruit such as raisins and apricots. Pharmacological recommendations. Oral iron supplements are the cheapest, safest, and most effective treatment for iron deficiency anemia. The first step is treating the cause. With oral iron supplementation, 325 milligrams of ferrous gluconate daily, and then measuring hemoglobin, ferritin, and transferrin saturations monthly. If this treatment is effective, we're going to continue oral iron supplementation for 3 months, check red cell indices and iron status monthly for 3 months, and then every 3 months for a year. If the symptoms persist, further blood tests should be done every 3 months for another year, and iron supplements should be given. If iron status is maintained, there's no further investigation needed. If iron status is not maintained, consider further investigation. If the patients are on the oral iron supplementation and measuring the hemoglobin, ferritin, and transferrin saturations and monthly, and it's not effective or they're having poor tolerance, need to check adherence, investigate iron malabsorption, eradicate Helicobacter pylori, and check a drug history. If these treatments are still not being effective, then we may have to consider parenteral iron supplementation and then check the labs as indicated by the algorithm. Regardless of the presence of symptoms, all patients with iron deficiency anemia and patients with iron deficiency without anemia should be treated. The cause of iron deficiency also must be identified and addressed. This is especially true in adults with new onset of iron deficiency. Some health conditions may affect iron dosing and the route of administration. Uncomplicated iron deficiency anemia can be treated with oral iron. Dosing of oral iron supplementation depends on age, the estimated iron deficiency, and how fast the deficiency needs to be corrected. Side effects of oral iron include metallic taste and a number of gastrointestinal effects depending on the dosage amount. Strategies to improve tolerability of side effects needs to be individually addressed to maintain compliance. In some situations, such as treating pregnant women, individuals with inflammatory bowel disease, ongoing blood loss, or treating chronic kidney disease, intravenous infusion may be indicated. Intravenous administration may also be indicated in individuals with anatomic or physiological abnormalities that interfere with absorption or severe intolerance to oral medication. A resolution of initial symptom, a rise in immature red blood cells peaking in 7 to 10 days, and normalization of the hemoglobin level in 6 to 8 weeks is indication of effective treatment. If a patient exhibits a lack of response, re-evaluation, possible ongoing blood loss, non-adherence, or compliance, and additional diagnosis workup should be considered. All patients with severe life-threatening anemia should be treated with red blood cell transfusions. Pharmacological use. The usual adult dose for the initial dose is ferrous sulfate 600 milligrams PO every day for 3 months. Usual pediatric doses are 0 to 5 years ferrous sulfate 15 to 30 milligrams per kilogram per day. 5 to 12-year-olds ferrous sulfate 300 milligrams per day. 12 to 18-year-old males ferrous sulfate 300 milligram tablets orally twice a day. 12 to 18-year-old females ferrous sulfate 300 to 600 milligrams per day. Iron supplements should not be given with food or milk. Administration with orange juice enhances the absorption of iron. Iron supplementation provided to children and childbearing women diagnosed with IDA has been proven beneficial in restoring hematological indicators of iron. Iron supplements should not be given with food. Oral iron should be taken separately from milk, calcium-containing foods and supplements, cereals, dietary fiber, tea, coffee, and eggs. Iron should be given 2 hours before or 4 hours after ingestion of antacids. Administration of a 250 milligram absorbic acid tablet or a half a glass of orange juice will enhance the iron absorption. Treatment with oral iron may take as long as 6 to 8 weeks to correct the anemia. The repletion the iron stores may take up to 6 months. Follow-up of lab values should be drawn 4 weeks after start of treatment. Iron supplementation in pregnancy. There are risks to the fetus without maternal supplementation. Iron supplementation in pregnancy is recommended. Screening for idiopathic anemia is recommended for pregnant women. If left untreated, iron deficiency anemia can cause complications for the mother and the fetus. Increased iron demands occur in the second and third trimester of pregnancy. Mothers should be educated on increasing their iron intake. Iron deficiency anemia in pregnancy can be associated with cognitive issues in the fetus. Prevention and treatment with iron supplements during pregnancy or increased dietary intake. Risk to the fetus without maternal iron supplementation can cause premature delivery, low birth weight, decreased cognitive function in the newborn, and the possibility of maternal mortality. The implications for practice. Iron deficiency anemia affects patients across the lifespan. Practitioners should screen patients for risk factors for IDA and also assess clinical presentation and laboratory results. They should prioritize an evidence-based plan of care to prevent further complications. Prevention of iron deficiency anemia early in childhood should continue to be a priority to all healthcare providers. Screening for IDA may lead to earlier identification and earlier treatment, which may prevent serious negative health outcomes. Conflicting recommendations from the CDC, the USPSTF, American Academy of Pediatrics, and American Academy of Family Physicians imply that healthcare providers need to determine who is at risk for increased iron deficiency and screen to prevent negative health outcomes. The Centers for Disease Control and Prevention recommends screening for iron deficiency anemia at ages 9 to 12 months, 6 months later, and then annually from ages 2 to 5 years in infants and preschool age children who are at high risk for iron deficiency anemia. The American Academy of Pediatrics recommends universal screening for anemia at age 12 months and selective screening at any age in children who are at increased risk for iron deficiency or iron deficiency anemia. Consistent with the USPSTF, the American Academy of Family Physicians concludes that the current evidence is insufficient to assess the balance of benefits and harms of screening for iron deficiency anemia in children ages 6 to 24 months. Iron deficiency anemia can be associated with cognitive issues, is prevented and treated with iron supplements or increased intake of dietary iron. The U.S. Preventive Services Task Force concluded in the final recommendation statement, iron deficiency anemia in pregnant women, screening and supplementation in September 2017, that the current evidence is insufficient to assess the balance of benefits and harms of screening for iron deficiency anemia in pregnant women to prevent adverse maternal health and birth outcomes. Healthcare providers need to provide focused education and awareness strategies designed to improve nutritional habits for iron consumption. If the detection of iron deficiency remains, the goal then, consideration of screening for serum ferritin levels at 15 to 18 months may identify the largest number of affected children. Implications for practice in influencing the health of individuals. In order to influence the health of individuals who are susceptible to iron deficiency anemia, yet remain unidentified, certain risk factors do need to be considered. Sociodemographics and race are risk factors that can help to identify at-risk populations that could have higher incidences of iron deficiency anemia. As healthcare providers, we should consider the socio-demographics and race of individuals, focused education on role of dietary intake with iron-rich foods, identify strategies to increase patients' tolerance and compliance to medications, instructing and teaching patients about the medication and side effects to report, encourage follow-up appointments, and discuss with patients on the importance of reporting any new or changing symptoms they experience. Provide recommendations to control any conditions that lead to iron deficiency anemia and instruct on the importance of caution when returning to activities. In summary, iron deficiency anemia affects patients across the lifespan. Practitioners should screen patients for risk factors for IDA and also assess clinical presentation and laboratory results. They should prioritize an evidence-based plan of care, prevent further complications. Anemia is associated with diminished quality of life and increased risk of morbidity and mortality. Utilization of a complete health history, assessment and proper lab test, a diagnosis can be made and a patient can be managed. Management with oral supplementation is recommended. Intravenous is indicated if life-threatening or if oral supplementation is not tolerated. Alterations to dietary intake by increasing intake of iron-rich food is indicated. If no response to treatment, a referral may be warranted. Providing healthcare providers with adequate knowledge, diagnostic information, and treatment plans will enhance patients' outcomes and decrease mortality and morbidity in infants, children, childbearing women, and the elderly population. Iron deficiency anemia is associated with impaired immune function, impaired neurocognitive development, and impaired psychomotor function. These consequences in the pediatric population are often irreversible. Prevention of iron deficiency anemia early in childhood should continue to be a priority to all healthcare providers. Prevention of further deaths, low birth weights, premature infants, and gastrointestinal bleed is vital to the care of individuals entrusted to our care as healthcare providers. Thank you for your time.